So next we have Dr. Bhavani Pasupula, a study of clinical profile of optic disc edema in patients above 18 years at tertiary care center.
Very good afternoon to one and all present here. I am Dr. Bhavani from Sarojini Devi Eye Hospital, second year junior resident. Here to present on a study of clinical profile of optic disc edema in patients above 18 years. Author being myself and co-author being Dr. Adal Gupta sir. I have no financial interest. Optic disc edema, it is defined as an axonal distension and elevation of the optic disc, whereas papilledema is a term which is exclusively used for the bilateral optic disc edema, which is secondary to the intracranial increased intracranial pressures. Swollen optic disc edema, choked disc, or elevated optic disc are the terms which are frequently used to describe the swelling of the optic nerve. The clinical causes for unilateral are most commonly the optic neuritis, the non-arthritic anterior ischemic optic neuropathy, compressive optic neuropathy, etc. Whereas bilateral, there are papilledema, there is intracranial space occupying lesions, idiopathic intracranial hypertension, and malignant hypertension. The aims and objectives of my study are to determine the clinical manifestations and etiology of the optic disc edema, and my study is an attempt to prioritize the diagnosis. It includes both unilateral and bilateral optic disc edema. Materials and methods, it is a non-randomized prospective case study in the patients presenting with optic disc edema with unilateral and bilateral presenting to the ophthalmology OPD. All patients, we underwent a complete medical examination including blood count, blood sugars. Wherever necessary, we have advised for a CT MRI scan also. A complete thorough ophthalmic examination including anterior segment, pupil examination, slit lamp examination, and optic disc evaluation was done to these patients. Inclusion criteria for my patients were the proven case of optic disc edema and the proven case of papilledema, whereas exclusion criteria are the cases of pseudopapilledema. Coming to the analysis, in my study, the female preponderance is major. They are up to 64% of my patients are female, and 34% of them are male. Distribution of patient in relation to laterality, 29 patients of them have unilateral disc edema, whereas bilateral, 21 patients show bilateral disc edema. Distribution majority of them fall under the age category of 31 to 40 years, followed by greater than 50 years. Coming to various etiology, in my study, the majority of them have optic neuritis, like 18 patients have optic neuritis, followed by retinal vein occlusions, and some of them have intracranial space occupying lesions, idiopathic intracranial hypertension, IIH. The major symptoms are the diminution of vision associated with the headache in intracranial space occupying lesions. Coming to the best character visual acuity, most of my patients fall under the BCVA of 6/6 to 6/18, and followed by CF3 meters to PL positive. Associated systemic conditions, 44% of them have diabetic mellitus, 40% have hypertension, 2% of them have HIV and epilepsy, 4% have CAD, and 24% of them have no clinical comorbidities. Coming to the case presentation, this is regarding a 21-year-old female presented with chief complaint of right eye diminution of vision since 5 days. Anti-segment evaluation showed grade 2 RAPD. We have subjected her on to dilated fundus examination. There were significant disc edema in the right eye with the distribution of the multiple hemorrhages along the superior temporal vein. FFA was advised for this patient, which shows blocked hyperfluorescence and disc ischemia. So after thorough evaluation, we diagnosed this patient as optic neuritis and started her with a standard therapy of intravenous methylprednisolone. This was after 1 week after the treatment. There was significant improvement of the visual acuity and also diminution of the hemorrhages, as you can see. The case 2 is of a 36-year-old female which was referred to the ophthalmology OPD because of the holochronal headache. There were no systemic comorbidities. BCVA in both the eyes was 6/9. Anti-segment evaluation was normal. The patient has grade 4 papilledema in both the eyes. She was then subjected to MRI scan and CSF analysis. MRI was normal, whereas CSF analysis, which all the parameters were normal except the opening pressure, which was of 280 mm. We then diagnosed this patient for intracranial idiopathic hypertension and started with the acetazolamide standard therapy, 250 mg QID. Coming to the third case, a 65-year-old patient presented with chief complaints of DOV in right eye since 6 months. Known hypertensive, he has altered lipid profile with deranged cholesterol and triglycerides. On anti-segment evaluation, there was a grade 2 RAPD, with the rest of the evaluation being normal. On dilated fundus examination, there was significant disc edema with multiple hemorrhages. He was diagnosed with right eye central retinal vein occlusion and was started with intravitreal Avastin therapy. Conclusion, We found that the common etiologies of optic disc edema were optic neuritis, idiopathic intracranial hypertension, retinal vein occlusions. Majority of patients were female with united presentation. The common complaints were decrease of vision and headache. With causing ranging from the infectious to vascular to the malignant, the swollen optic disc is a crucial, often mystifying sign. Patient vision or life may depend on the timely diagnosis, hence early detection and management are essential to prevent the progression of disease and loss of vision. These are my references. Thank you.
Thank you, Dr. Bhavani. I think that's important for us to know about what is the clinical profile and final diagnosis in these patients. But it's a big mixture of things.
Yes.
When you say optic disc edema, unilateral, bilateral, with vision loss and without vision loss, it is going to be a mixture of things. So you can subclassify your results later on as patients with papilledema versus optic disc edema. That will segregate the disease being in the brain versus in the eye only. And then in that you can represent the results with vision loss and without vision loss. That might give you more meaningful information. Thank you.
What was the commonest cause you have found amongst the youngsters?
It is optic neuritis, sir. Majority of them from 21 to 30 years have presented with optic neuritis only.
Older generation?
Older generation retinal vein occlusions are more common in hospital settings, sir. Like central retinal vein occlusions are more common. Some of them have IIH, idiopathic intracranial